So good morning. So today's first case, short case, our candidate is Dr. Saurabh is here. So he will assist it's a more of a formal chit chat just to know the ways of how to give a exam, that to a MS exam. So Dr. Saurabh, how are you? Fine.
Yes, sir. I'm good, sir.
So tell me your diagnosis of your case.
So the diagnosis of my case is fixed flexure deformity of left elbow, approximately 20 degrees, following fracture distal ribs.
So when I ask a case of his diagnosis in a short case, how do you give a diagnosis? Is it the way that you are giving is correct? Short cases are supposed to be nowadays the trend is that there is that differentiation between long case and short case is going on. So now it is a case. So any exam you go like a DNB or FRCS, so there will be cases. So that differentiation that traditionally was there is no more there. But even then, if the examiner is asking you the straight away diagnosis, how do you describe your diagnosis of a short case?
Should I show the full history?
So history point, see, I'm not told you to tell you the history. I've just today I've asked you some not even a summary. I just straightforward. I'm asking a diagnosis because short cases are supposed to be spotters. It's long cases traditional. You take whole history and then summarize and then come to a diagnosis. But short cases are supposed to be spotters. The moment you see it, you develop a diagnosis. Understand? Because in OPD setup also, you don't have time. Any patient gives you 5 to 5 minutes max. So you just have to look at the patient, take some relevant history, and arrive at a diagnosis. So that is an art that you have to develop. Understand? So what do you think should be? How do you describe a diagnosis? Short case.
So my patient Sanjeev Kumar,
Good. So first you have to give a demographic data.
38 years of
Uh,
age, male,
Mhm.
uh,
Good.
came to orthopedics OPD with complaints of pain in
No, no. See, I'm not asking you history. I'm asking you diagnosis. So one thing you have to give a demographic data, that age, sex, and also occupation. क्या करते हैं हम?
drive.
So we have to give the occupation also. Age, sex, occupation, and handedness. Which कौन सा हाथ आप ज़्यादा right left कौन सा इस्तेमाल करते हैं? Left hand. वैसे आप right ही है left ही है? Right ही है. Right handedness. Right dominant hand. So it's because you are taking a case of upper limb. So that handedness is very important. Then after you give a demographics of the patient, then you have to give the anatomical diagnosis and pathological diagnosis. So what is the anatomical diagnosis in this case?
So fixed flexure deformity.
No. Anatomical diagnosis is not you are telling what you are telling is finding, palpatory finding. What you are telling is findings. You are not telling. See, diagnosis is two types. One is anatomical diagnosis and one is pathological diagnosis. So in this case, the duration is of he had a fracture in
7 years, 2015.
so it's a 7 years old united or non-united?
United.
United fracture with implant in situ. Understand? Of then anatomical lesion will be distal humerus. So this much you have to tell. So this becomes your anatomical and your pathological diagnosis. Then comes you have to give. Then you come functional limitation. What is functional limitation now? Then that your physical findings. That you told flexion deformity of 30 degrees
Yes.
and
And so decreased range of motion. Flexion is limited to 20 to 120 degrees.
so when diagnosis is just tell broadly you have to tell fixed flexion deformity of 30 degrees with limitation of activities of daily living. Understand? So basically there are 9 points in a short case. Age, sex, occupation, handedness, anatomical, pathological, and functional limitation, and you have to end with functional limitation. Understand? So then your diagnosis is complete. And if you tell uh, just one thing, so now even though you have not given the diagnosis, uh, the actual you have not given now your this pathological diagnosis. Anatomical you have given united fracture. Pathological will be his what is his complaint now? Can you describe one thing about his elbow? One diagnosis.
So he has a limited range of motion and which hampers his day-to-day
No.
activities.
So have you heard about stiff elbow? So basically now he's suffering from stiff elbow. That is post-traumatic heel fracture leading to a stiff elbow. Basically now his concern is that he is not able to use his limb properly. Understand? He is a driver of profession. He wants a very good limb. Is not able to use that limb properly. So his main concern is that he is not able to drive. Understand? So your diagnosis should be post-traumatic heel distal humerus fracture leading to stiff elbow. So that should be the complete diagnosis with your all the things I told. So the almost short case diagnosis is of paragraph. So now you want to revise the points I'm telling. Now you want to revise the diagnosis. Now the points we discussed. See, it's more of a training exam. I'm training you for DNB exam or FRCS exam or higher exams I'm training you. Don't take it that I'm examining you. I'm training you for standard international level exams. There, it should be crisp. The more you present, see, it is all about presenting. The more you are presented and discuss, this is all on an art and format. Understand? So now, just what we have discussed till now, you try to summarize your diagnosis in those points.
So my patient is a name 38 years male, Indian male, driver by profession, right-handed person.
Very good.
Uh, the anatomical diagnosis is
So you did not tell an anatomical diagnosis. This is because as if when you're presenting history, you will not tell chip complaint, pending complaint. That is obvious. It should be flow. Don't tell those headings. Headings should not be told. Headings are only told for us to keep in mind. But actually, we have to give a diagnosis in a single flow. Now again,
um, the, the diagnosis of the patient is post-traumatic stiff elbow, post-traumatic heel distal radius fracture, distal humerus fracture leading to stiff elbow.
so you left the demographic. You didn't tell. Again, you have not told demographic. You didn't tell radial. So you have to tell everything. Again, you try. So this is all try. Try.
So my patient Sanjeev Kumar, 38 years, Hindu male, driver by profession, is from Delhi, right-handed person, uh, is having post-traumatic stiff elbow of the left side.
Go on.
And um,
Some findings, physical findings.
so patient has a fixed flexion deformity of 20 degrees on the left side, and following the distal end of humerus fracture,
Heel fracture.
heel fracture, heel any
So
distal end medial.
you are getting it, but you have to practice it because it should sound good also. Understand? So sound good will only happen when you keep on telling the diagnosis. See, because see, if you tell me stiff elbow, then I will ask you those points that related diagnosis only. What is the age? What is this, that? So basically, the thing is that you are not allowing your examiner to move to higher level, and you're just stuck on a very ground level. Understand? So the marking pattern is that see any examiner has no bias against the examinee, and even if you go so some places where the examiners will not know you, first time you're meeting, So there is no bias. Examiner just wants to follow a format and he wants the examiner to answer in a format. So we have to catch that format to scoring good. If you can catch that format, you score very good marks. Otherwise, if you're not, your format is not good, the examiner thinks that the candidate has never presented any case in his residency program. Understand? And the marking pattern of any examiner, he starts with 50%. If it is 20 marks per short case, I will start with 10. 10 I will straight away will give you. But the net performance, how much you score, it's like a roller coaster girl. You take me up, you take me down, you take me up, you take me down. So at the end, I will see where I am. Understand? So it's a roller coaster ride of the examinee with the examiner. So there is no bias. So you are leading me to what marks you are getting. Understand? So that is, you just try to understand the psyche of examiner. So nobody is there to harass you. Nobody is there to fail you. So we have all gone through this stage. Understand? So now we understand, being in this side of the table, that actually there is no such bias. It is only the your performance, and maybe if there are five candidates that day, the relative performance of other candidates. If I have to pass 5 out of 2, I will select the best two candidates. Simple. If I have to pass 5 out of 5, I have to pass the whole candidate, whole lot. So it is up to your performance, and performance is very simple. You have to just catch hold of the format of the exam. Any exam, for per se, anywhere, there is a fixed format, and if you can catch that format, you score very well. So this is the diagnosis. Now coming to the other question, what are the points in favor of a diagnosis? You have given this diagnosis. Now tell me, what are the points in favor of a diagnosis?
So my findings of this case is on inspection from front
So
side.
you have to start with history. When I'm telling you findings, you start with history.
So patient was apparently alright 7 years back.
No, tell me the gross things. You did not tell the whole history.
So patient had fallen from the stairs 7 years back when he got admitted in RNL hospital in Delhi when he was operated for distal and the femurous fracture. Where two recon plates were applied on the distal end of the radius with all-in-one K-wire fixation was also done. After that, patient developed this pain in the left elbow region, and the daily activities were limited due to pain. And later on, patient developed the fixed fracture deformity of approximately 20 degrees on the left side of the elbow.
So what are the findings? See, now you have ruled out. Have you taken the relevant negative history? What is your negative history?
So there is no history of fever or diurnal variations of pain, and there is no history of any inflammatory disorders, diabetes, mellitus, or any chronic renal diseases or liver diseases.
So always, whenever you're taking history of parenting illness, you have to take a relevant negative history also. So in this case, it's obvious that it is post-traumatic. But I'm telling you, if not a just history of say elbow pain, and he's coming with this stiffness or restriction, then the negative history is very important. In this case, it's obvious. But even then, in all cases, see, as an examinee, you are not supposed to skip anything. So that format is fixed. You have to go through the whole format. Understand? So as such, there is no significant negative history. That you can tell. Okay. Now coming to what are the positive findings? So positive findings means what I now am interested to know is the whole base of orthotics is on look, feel, move, measure. Understand? So that is orthotics. Look is inspection, feel is palpation, move is you have to check the joint movements and do some relevant measurements also, because orthopedicians are carpenters also. At the end of the day, the purpose in this case is to give me some functional restoration of the result. He has not come for his fracture or non-union. Everything is healed. healed well. But what he has come, then you have to discuss with the patient why he has come and what is his expectations and what he wants. Understand? And also, before deciding on a procedure, you have to also discuss his economic status also, because your management should be tailor made to according to the patient's needs and his economic status also. You cannot advise something very costly to a low society. So that is very important. You have to discuss everything with your patient, then only devise a plan in consultation with the patient. So that is what required. Understand?
Should I tell the prescription?
You tell me the positive findings.
So on inspection from front,
So now tell me the positive findings. Yes, yes.
on inspection from the front, back, and from the side, my findings are there is
Very good. You have to do circumferential inspection. Very good. So अपना खोल लीजिएगा शर्ट प्लस शर्ट डालिए ये पूरा उतार दिया था आपको हीटर चल रहा है कोई बात नहीं डॉक्टर सरोज डिस्क्राइब द क्लिनिकल फाइंडिंग्स
so there is
ठीक है
fixed there is a fixed flexion deformity of the left elbow and
no tell me like inspection palpation everything you tell
so on inspection from the front, from the back and from the side. So my first finding is there is a fixed flexion deformity of the left elbow.
see fixed flexion deformity is not an inspective finding tell you it's a palpatory finding what you can tell is there is a deformity and elbow is looks like flexed so inspection means just what you are seeing with naked eyes inspection see these are compartments inspection, palpation, movement, these are separate compartments. You cannot jump, understand? Here and there, here and there. So inspection means just what you are seeing with naked eyes. That you have to describe. Not describe.
So inspection from the front, back and from the side. I can appreciate there is a deformity in the left elbow.
Very good.
There is no sinus swelling on the anterior aspect of the elbow joint. But if you move posteriorly, you can see a scar on the posterior
Very
aspect
good.
of
See, so this scar. So you can see a scar healed by primary intention, secondary intention.
primary intentions.
Primary intention. Very good. Good.
On the distal end of the distal elbow uterus ascending to the elbow joint.
No, this upper third forearm. It's not a. Understand?
Till of the organ.
Yeah. Okay. Then
Then, sir, there is no muscle resting of the arm and the forearm.
you see there is some more wasting. You see carefully, there is a wasting of the muscles. You see carefully, see, there is a wasting of the muscles. Can you see, appreciate or not? See, there is some more, you cannot tell there is not wasting. It has to be. There has to be some wasting. Okay, go ahead.
Then, sir, there is no erythema or local, there is no erythema sinus swelling on the arm, elbow front, and forearm. So, this is my inspection.
हाथ कैसे करिए? Now you see. Can you see something? This is almost straight. Here in this position you can see some amount of flexion deformity. अब हाथ को ऐसे करिए मोड़िए. Restriction. You can see the appreciated restriction also.
Yes.
सीधा करिए. चलिए. You appreciate it? So anything else? Any finding? Anything else? How to finding is
This is a white patches on the forearm.
white patches. It is instructed. And now come to palpation.
So,
How do you palpate? Palpate. How do you start palpating? What is the thing you palpate first?
so we palpate the medial condyle.
No. You palpate first the local range of temperature. The moment you start palpating, you just put your hands and check for temperature. Understand? The first thing that you palpate in any joint is temperature crossing the hand. Understand? Because by the whole process of viewing the movement, you can erroneously increase the temperature of the part. So, moment you start palpation, and you have to. And one thing is very important that you have missed. What you have missed nowadays,
Um,
you have to explain the patient that Mr. आपका नाम क्या है? संजीव कुमार जी, आपको आपको मैं ये मूवमेंट चेक करना चाह रहा हूँ, मैं ये मूवमेंट करूँगा, ये मूवमेंट करके देखूंगा, ठीक है, एंड यू हैव टू डिमॉन्स्ट्रेट ऑन द नॉर्मल साइड. Always orthopedics it is comparatively. Always you have to first examine on the normal side, then you have to examine on the affected side, and you have to take consent of the patient. You have to take consent at this stage and beginning also. You have to introduce yourself. I am Dr. Saurabh, plan of the doctor. So now I have come to examine you. So you have to start examination with the consent of the patient, and before also you have to examine. Nowadays, since it's cold, you have to rub your hands also. Don't touch your patients with a cold hand. Got it? So you have to properly rub it. Then only, because you have to make a patient comfortable and develop a rapport with the patient. Understand? Unless you develop a rapport, patient will not cooperate and many things will miss. Understand? So go ahead. I'll take consent and pulpit.
मेरा नाम डॉक्टर सौरभ है, मैं ऑर्थोपेडिक्स रेजिडेंट हूँ फर्स्ट सेकंड ईयर. आपका एग्जामिनेशन करना है मुझे इन्फॉर्म कीजिए. So we check for localized temperature first.
Okay.
There is no localized temperature.
Go ahead.
Check. Then we palpate the medial contact, lateral contact of the humerus and the collar. There is no tenderness on three bony points. Then we check the three bony points relationship.
Very good. Yeah, that's what you said. And it's a comparative thing. You have to check both sides. ये दोनों मोड़िए, इसको मोड़िए. Now you put your fingers and no, you have to put your fingers. No, yeah, marking also and put your fingers also like this. Understand? Like this. You have to put your fingers also like this. Understand? Then you have to see for the measurement. How much is the medial distance? How much is the this base distance and this thing? So it is the same.
Same.
So this you have this is I'm telling you always I'm emphasizing you that orthopedics is a comparative thing. You have to always compare the normal side. So here the 3.1 relations is
It's maintained.
maintained. Good. But
Then sir, that's my application.
so would you not like to check the movements of the element? How do you check for that?
So we flex and extend the elbow.
How do you do that?
So we ask the
आप इधर आइए इसमें संजीव जी ऐसे इधर आइए इसको आगे हाथ पैसे रखिए हाँ उस हाथ से दबाइए उस हाथ से दबाइए आप सीधी करिए हाथ can you see? So this is where is the volumeter?
something like that.
Can you bring it?
Yes.
Volumeter level. How much FFD is there? 25 25 almost 25 26 as far see now after you have quantified the FFD, what is the further range of flexion? This is how much the now measure how much further flexion. No, this angle you have to measure. This angle. You keep one bar here and one bar this angle you have to measure. This angle, this and this angle. You have to measure. No, not getting that angle. This angle.
Okay.
How much this?
It is 135.
135. So FFD is 30 degrees and from 35 to 135 degrees is the range of motion. So whenever you tell the range of motion, first you tell FFD, then you tell active range. Active is patient is doing, then further passive range, and you also tell whether it is painless or pain free. with capitus. So this whole thing you have to summarize. Understand? So in this elbow you can, but these are the components of telling the uh, finding the elbow range of motion. FMT, range of passive motion, so active motion, passive motion, associated with any pain, capitus, or axis deviation. So this much you have to tell. So the range of motion is here is 30 to 135. So now what is the other thing that you would like to palpate?
So we already calculated medial to compare lateral to compare the mass.
Hmm. 3.1 is the palpate. Movements you have checked. Anything else? What was interesting to see? How do you check for the radial head? That is very important.
So we ask the patient to flex his arm and we put our hand on the lateral aspect of the elbow. There is a
Where you want? Where the hand is? Where the hand is put? Where you put your thumb? See, it is given in as thus. As thus is the Bible of examination. First book that you should study is as thus. As thus, which was written 100 years of back, is still relevant for orthopedics and surgery. So in as thus, it is written that you have to feel for the radial head by what? By asking the patient to supinate and pronate. Understand? That is the radial head. But the thing is that if you palpate the lateral supracondylar ridge and just go in front of that ridge, I mean just go in front of the lateral epicondyle, the first thing that hitting is radial head. Understand? Understand? And you just confirm by supinating and pronating. So sometimes in say a Montegia fracture, the radial head will be missing. It will be dislocated. So that is a very important diagnostic step. Radial head is a very important diagnostic thing. So you should know how to palpate radial head. Got it? So what about the measurement?
So we already measured the FMT, which is approximately 25
No.
degrees.
Anything you have to like to measure in axial range?
So we can measure the carrying angle.
Very good. So in this case, can you tell about carrying angle in this case?
No, sir.
Why?
So the limb is not fully
Fully
extended.
extended. Very good. You can comment on a carrying angle only when this full extension is possible. If there is a pressure deformity, it is not possible to comment on a carrying angle. So anything about the limb measurement that you can do. You have pencil tape. Anything you check for the vesting. You tell inspector finding it was there. Now you check for the vesting here. So first you have to measure on the normal side always. Anything you have to do first to normal then abnormal.
So here is the normal is 10 inch.
Mhm.
Here is 9.5 also.
So there is
Wasting
wasting of how much? 5 centimeter?
0.5 inch. 0.5 inches.
0.5 inch means it is around 1 centimeter. Good. So, see, so whenever you are doing palpation, whatever you have told in inspection, all those findings should be corroborated when you palpate. Understand? It's not that you tell something in inspection and tell something in palpation. It's like a flow. It's like a music. It's like a rhythm. So whatever you have discussed in your inspection, you have to corroborate in your palpation also. Understand? So, so this must anything else that twisting is there, FFT is there, restriction of movement is there, and what about the separation progression? Have you checked? ये करिए साइड में करिए इसको सटाइए इसको नो नो इसको हाँ अब ऐसे करिए
Consider
ऐसे मोटा करिए ऐसे करिए सीधे करिए ये करिए So it looks supination pronation is more okay. Okay. Now anything about his length now? Upper limb length. How do you measure the upper limb length? How do you measure? Have you measured his upper limb length, or from which points you measure? So you measure from the lateral end of acromion to epicondyle and epicondyle to this tip of the index finger. So two lengths are there, forearm length and your arm length and forearm length. You measure it. Tell me, is there any difference? First measure on normal side and then normal side. So why I'm emphasizing you, these things are very important. So there is a difference between UG and PG exam. As a UG candidate, you will be spread. Understand? But as a PG candidate, you will not be spread. You have to do everything that is written in the books, the examination manual. It's like flying an aircraft. Before flying an aircraft, the pilot checks everything, engines, flaps, everything working, and tick marks. So when you are giving a postgrad exam, you must. There is no relaxation at all. You have to follow each and everything.
See, so the length of the upper limb on the right side is 65 centimeters, and on the left side it is 63 centimeters.
So there is 2 centimeter shortening of the arm. And what about the forearm? It's same or
So forearm is the same size.
same? So now you see there is shortening in the arm. I can make out. If you see the crease, you see these creases are not the same way. Because the vertical detail, but I can definitely make out some shortening. You see here, grossly some shortening is there. You see? Can you see?
Yes.
You see the tip of the small little finger. There is some shortening is there. Now where the shortening is from the arm length. So see, so many things are there. So why these things are important? When you are going to manage this patient, then this thing should be in your mind that there is 2 centimeter of shortening of the arm. So whatever procedure I do, I have to gain that amount of length. Got it? So this is relevance. If you have not seen this shortening, if you have not seen this FFD, how will you manage? Understand? So now we almost finished instruction for this findings. Now tell me, uh, now tell me the plan. What is the plan now?
So the plan is to remove the implant, the recombinant and the tension band wiring, and do a corrective osteotomy to correct the fleshy deformity.
Corrective was not well. Now, Dr. Saurabh, tell me what is the plan in this case? What you will do?
So the plan for this case is to remove the implant, the two recombinants, and the tension band wiring and the other device. And following that, we can increase the RP by doing regular physiotherapy.
So, uh, this stiffness was bony stiffness or soft tissue stiffness? Did you check for that? Because stiffness can be of two types. It can be a bony engagement or it can be because of some adhesions and contractions. So, in this case, what do you think it was? Which type of stiffness was there?
This is soft tissue fracture.
So, how do you differentiate between soft tissue and bony stiffness? So, how do you differentiate between bony and soft tissue stiffness?
So,
When I, whenever you examine a case of, because this is a case of stiff elbow, more or less whatever that basically now elbow is become stiff. So now, whenever you have get a case of stiff elbow, the thing is that you have to decide whether it is stiffness is because of some bony impingement or some contraction. How do you do that? What are the examination findings?
So I cannot find any bony pathology due to any contraction to any bony property because the 3.321 relationship was maintained and um, there is no there is no any extra bony prominence on the elbow joint as well, which must be restricting the flexion. So my most probable diagnosis is a soft tissue contracture. That's why I think
It's an extra-articular, it is.
yes.
It's not articular. What you do. But in this case, see, you cannot tell also because this is a fracture of having distal elbow involving the joint. So you cannot completely rule out intra-articular because this fracture is from the joint. So basically, it has both components, intra-articular and extra-articular. Understand? Because it is a post-traumatic case. Understand? So, what will be the plan? Your first plan is you will remove the implant. Then, what you want to do?
So we can go for physiotherapy of the elbow.
Any surgical procedure you can do while removing the implant. You have removed the implant, you have to do everything. Understand? Any surgical procedure that you can do.
So we can do a slowly.
Osteotomy. Why you want to do osteotomy? Is there any malignant? Then
There is a deformity
which deformity is there?
exclusion.
Then that deformity is because of adhesions, because of stiffness, maybe because of intra-articular extra-articular. So for that you don't need to do osteotomy. Here it is perfectly healed fracture. Understand? So in this case, I mean anything that you can do on table after you have removed the implant.
So we can
You told something about soft tissue. So do some soft tissue releases and see how much movement it is getting. Understand? So one thing is very important. See, this case was not done by you. It has come from elsewhere. It is operated. Now it has come after 6 years. So what will tell the patient? What will console the patient?
so I can prognosticate the patient that the deformity may take time to get corrected and it might not be
Stiffness may not improve.
yes,
One very important thing in implant surgery is what is that?
reinfection.
Now, very important thing. Whenever you remove an implant, what is the thing that you should explain to your patient?
So the screws might be broken inside
Yes,
and
you have to tell the patient that you, it may not be possible to remove the whole implant, or even while trying to remove implant, there can be a refracture. Because see, the removal of implant is a difficult surgery than putting implant. So you cannot tell. So you have to consult the patient. You have to take consent that it may not be possible to remove the whole implant. It may be possible to remove the partial implant, or there can be fracture also. It should be very very clear. There should be no ambiguity in this because if something happens, what forbid, the patient can sue you, take you to the court. So nowadays you have to be safe because thing is that the first thing is that as a matter of fact you should ask the patient to go to the original surgeon for implant removal because the surgeon who has put the implant knows best. If any other surgeon is trying to remove the implant, there is some amount of I mean, uh, uh, some amount of indecisiveness and some amount of lack of judgment can be there. Understand? So even the patient insists that आप इसे कराना, you should do it. You should take full consent. And while going for removal of implant, what instruments you will have on the OT table?
so we have the knife.
Like that is general set is there. General instruments will be there. Apart from general set, what other instrumentation you should have while removing this implant is a difficult fracture.
got rules that the OP should be there.
What is it? What is this called? It is called as
Broken implant.
broken implant set. So there are various type of drills. You can, uh, if the head is stuck on the screw, you can break the head. Carbon drills are there. Diamond drills are there. Understand? Special screws are there. So nowadays, you should have ideally in your OT the broken implant set. Without that, you should not touch the 7 fracture. Consent is mandatory and this implant set is mandatory. Otherwise, you should not be touching this such machines. Got it? That's all. So, what will your physiotherapy protocol?
So elbow range of motion and active flexion and extension.
For elbow range of motion, do you have any instrument that you can use in post-op? You heard about continuous passive machine, CPM machine? They put it because they put the patient on CPM machine also. You have seen that machine? So post-op protocol should be a lot of icing. Icing should patient should do a lot of icing because a lot of fibrosis can add broken adhesions and post-op bleeding can be there. So you have to do a lot of icing in the post-op and put if you have a machine, CPM machine, put the machine in CPM machine for a few days so that you gain some more information. Apart now, the thing is that what are the complications you expect in this case?
There can be infection between surgery. Right.
So whenever I uh, talk about complication, you should think about immediate, intermediate, and late complications. So what can be the immediate complications? Such as this? One thing is that you are not able to retrieve the whole implant. There can be fracture. These are on-table complications that can develop. What can happen in post-op? There can be infection, bleeding, hemorrhage, all these things can be there. And what are the late complications can happen in this case? In the elbow case? What do you mean by myocarditis ossificans? Can it happen in this case? Myocarditis ossificans.
Is during physiotherapy.
So elbow is notorious. El- Especially the 6 years old elbow is very notorious. This can go for myocarditis ossificans. Understand? So that also you have to keep in mind. So is there any medication that you give in post-op to prevent myocarditis ossificans? While discharging any drug that you know that you can give to patient. That is indomethacin. That is good. If you don't know, don't waste the time examiner. You tell the examiner, I don't know. Because in the exam setting, in the PG exam setting, you should not, if you know, no. There's no, I mean, no point doing a guesswork or no point wasting the examiner's time because more examiners are waiting. So if you don't know, tell you rightly or said, you don't know. Okay. Okay. Well and good. How are you? Fine. Comfortable?
Yes, sir.
So this is the last section of exam. No?
Yes, sir.
So it's a short case.
Yes, sir.
So Dr. Vio, tell me your diagnosis. What's your diagnosis of the case?
My case is operated case of fractured tibia shaft, right side with interlocking intermedullary knee.
So when I have told you to give diagnosis of a short case, what is the way of giving it? What is the style? How do you give a diagnosis? What are the points of a diagnosis in a short case?
ये diagnosis is really क्या फ्रैक्चर था, क्या ऑपरेट हुआ, क्या उसका
See,
Plant
giving a this is a short case,
yes, sir.
and short case if the examiner is asking you to give a diagnosis, there is certain format. So what is that format? And what are the components of a diagnosis in a short case? What are the components? First is your demographic data. So what is the demographic data of the patient?
Uh, Male, 64 years of age. My patient Gopal Singh, 64 years of age, resident of Hapur.
Very good.
He's currently not working, and
So previously you was doing some work?
no sir, 64 years.
Unemployed. Yeah, retired. You can say unemployed, retired.
Yes.
20%.
Yes.
Okay. Then you have to give the diagnosis are two components, anatomical and pathological. So what is the anatomical diagnosis of the case?
So fractured tibia, um, tibial shaft, right side.
Post-traumatic or what is the cause of fracture?
Sir, RT,
So you have to tell post-traumatic.
post-traumatic.
So because it is very important because whenever you give a diagnosis of fracture, you have to tell it is because of the trauma or pathological fracture. How to differentiate between trauma and pathological fracture?
Sir, trauma is an acute condition. In case of pathological fracture,
What is the definition of pathological fracture? What do you mean by pathological fracture?
a fracture which has occurred because of some kind of a metabolic disease or a disease inside the.
See, a fracture that has happened with less than the normal force required.
Yes.
The amount of force that is required to cause a fracture when it is suboptimal, say just a tripping down the stairs or some twisting as happens in old age, that is a pathological fracture. So in your case, it is not a pathological fracture, it is a proper trauma has happened. So whether then how do you tell whether it is a significant trauma or insignificant trauma?
So it was a RTA.
How to differentiate what is significant trauma or insignificant
So
trauma?
it was a significant trauma.
Why?
Uh, because of the way he told, gave his history.
No. What will you ask in history? That it is you can differentiate between significant trauma and insignificant trauma.
Sir, was the other by running?
No. Whether the patient was able to stand or not.
Not able to stand, sir. After that.
So that means it was a significant trauma. So the patient having sustaining some injury and not able to stand, that it was a significant injury. So that history is very important. Then this is a anatomical diagnosis, distal end of tibia fracture. How many days old?
Sir, 25 days old.
United, non-united.
Non-united, sir.
The process of healing. In the process of healing. The healing process has been done and so okay. So what are the points in favor of a diagnosis? See, once you have given the diagnosis, then the second question will be, and other thing is very important that I missed is one demographic data is there. You listen to me. The demographic data is there, diagnosis is there. Then you have to give what are the functional range of motion. Any functional limitation? Is there any functional limitation now?
Yes, sir. Functional limitation.
What is the functional limitation?
So he was not after accident. He was not able to walk.
Now what is the functional at present? What is the functional limitation of the patient?
So at present there is no functional limitation. The knee is can go into full flexion extension and.
So there is no access, no functional limitation.
No, sir.
Then you have to also tell about any surrounding joint involvement. Knee joint, ankle joint. Are they okay? Are they fine?
They are fine, sir.
They are fine. Okay. So basically it has 9 components. So see if you don't tell your diagnosis in one go, especially in a short case, what the examiner will do is keep on probing you. If you have not done the age, then examiner will age. If you have not done the occupation, examiner will ask you the occupation. If you have not done the functional limitation of the patient, examiner, what are the functional limitations? So don't give an examiner a time. So if you are giving the examiner so much of time to probe you deep, it means you are on the borderline. You are not allowing the examiner to go one step ahead. So as a PG candidate who is going to become a specialist after this degree, you are supposed to give diagnosis in a single go. Now can you revise diagnosis? Now the points we are discussing, you revise your diagnosis.
My patient, Gopal Singh, is 64 years of age,
resident of Aput, uh, post retirement, uh,
Retired.
retired. Uh, history and career assessment.
Diagnosis. History of the patient is diagnosis.
Verdict is an operated case of fractured tibia shaft right side with interlocking intermedullary
In situ.
incident
With no.
with no other joint involvement
Very good.
and uh, with, currently
What functional limitation?
with no function limitation.
And also you have to mention very important thing in orthopedics. Whenever you examine a case of fracture or post fracture, what is the very important thing?
So distal
Very distal neurovascular status.
with normal distal neurovascular status.
Again you try. Now I have given you it. Now again you give whole diagnosis in one line.
My patient Gopal 64 years of age, resident of Apos, retired, is an operated case of fracture tibia with fracture tibia shaft right side with interlocking intermedullary in situ with 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 no functional disability and knee and the ankle joint they are normal and with normal distal neurovascular status.
So how many days old is this? This is how many days old fracture?
Yes, sir.
How many days old fracture?
So when patient came here, it was 20 to 25 days old.
Already 3 weeks old.
Yes, sir.
So
Not irritated.
so this part you have missed.
Yes, sir.
You have to add in the diagnosis another three weeks old fracture tibia of distal thread. Understand? These things you cannot miss a very important thing. Understand?
Yes, sir.
So because 3 weeks is almost a time when fracture healing starts. Understand? So it's not a fresh fracture. Understand?
Yes, sir.
Okay. Then what are the what are the points in favor of your diagnosis? See, you have given this diagnosis. Now tell me the points in favor.
There is a surgical wound and anteromedial aspect of the leg.
No, when I told you points in favor, you have to start from history. Relevant points in history.
The patient was apparently well 20.
No, don't only tell me the relevant points.
So
You had history of
patient
trauma.
has fall. A patient, sorry, not the history of fall. RTA. Patient has a history of RTA, followed by severe pain, which was not relieved by medication, and there was abnormal mobility around the distal end of the leg. Then, for which patient took treatment from outside, a slab was given, and from a local practitioner, and then after 20 days, patient came here. Um, Um, on X-ray, we
Why? What was the reason of patient not coming after 3 weeks? Why he delayed his treatment?
so data aspiration.
Data. That is very important. Why delayed? Was there any history of any osteopathic management? Because sometimes these people go for local bone
Yes,
setters.
that's what I said. Local practitioner went for local practitioner.
That is important. No, he first he went to local bone setter.
That's the only thing I have mentioned, sir. A local practitioner treated him with a local slab, and he waited there for 3 weeks, not exactly 3 weeks, 20 to 25 days, and then he came here through marketing team bought him here, sir. Hospital's marketing team bought him here. He was
Why? So now,
patient felt not relieved from the condition. He went to the PACS, and then after a certain period of time, when the condition was not relieved, like pain, swelling, and abnormal mobility. Uh,
so basically, what were his parenting complaints? That will decide his management. What were the parenting complaints?
Pain in leg since 20 days. Swelling subsided with gradually. over time, and the only thing
Parenting complaint was pain.
was pain.
And only pain.
Only pain. There was no open wound and
Was he able to ambulate?
no, sir.
This will also come as a complaint. Pain, swelling, inability to ambulate. So these are all complaints that you have to take the history like that only. Understand? So this is the history findings. So what are the findings now on examination?
There is a surgical wound anterior medial aspect of the leg and anterior aspect of the knee.
Right. So you have to give your findings in look, feel, move, measure. Orthopedics, orthopedic examination stands on a platform of look, feel, move, measure. So what is look? That is inspection.
So, on inspection, there is no local rise in temperature and tenderness.
Okay. No, inspection now you have to temperature. Inspection means only you are using your eyes.
Yes, it's Swedish. When the patient
I'm telling you,
inspection, when the patient arrived, there was a there was an angulation at the lower end of the leg.
no, see, you are examining a operated case. Now you tell me inspective findings.
So there were scars scars in the aspect and the middle aspect.
Healed by primary intention or secondary intention.
That's a primary intention, and
And
there is no swelling, no tenderness, no local rise in temperature. Um,
tell me your findings, physical findings, inspection, palpation. One thing you told scar, anything else?
so no swelling noted, no local rise in temperature.
See, when these are separate compartments, inspection, palpation, movement, measurement. You cannot mix. This is a common mistake candidate do.
Yes, sir.
जब एग्जामिनर आपसे इंस्पेक्टिव फाइंडिंग्स पूछ रहा है तो यू टेल ओनली इंस्पेक्शन फाइंडिंग्स डोंट टेल अबाउट एनीथिंग एल्स इंस्पेक्शन आप बताएं कि दो स्कार है इसके अलावा कुछ
No swelling, no
एनी वेस्टिंग
no
Any
wasting,
obvious wasting?
no wasting noted, sir.
डू यू थिंक दैट 3 weeks for fracture will have no wasting is it possible
Yes, sir. No, sir. No,
do you
sir.
think it is rationally possible so we have not seen it there.
Yes, sir.
So patient has come 3 weeks after 3 weeks so it's not possible that
There's no wasting.
patient with a slap or 3 weeks will have no muscle wasting. It is not at all possible. Anything else? Inspection?
Angulation.
Inspection. Swelling, sinus, karma.
There's no
So,
scar mark.
positive findings. Once you have told the positive findings, if the examiner is asking only positive findings, tell the positive findings. If the examiner is not asked you anything, he is telling inspection, then after you have described positive findings, you describe the relevant negative findings also. So what are the negative findings on inspection?
There's no swelling. No edema noted.
See, swelling, sinus, karma, these are the
Swelling, sinus,
delicate veins.
scar marks are present. These
Karma,
are the surgical scar
no
marks.
swelling, sinus, okay.
Yes, sir.
No direct veins are there. So whenever you are examining, you have to that just as if you are examining any joint per se. Understand? So when you start examining, what are the points you see?
General inspection.
When you are examining some joint or some bony part, how do you proceed in examination? What are the things that you see?
So first we will look for is there any signs of inflammation?
No. Basically, what are the things?
These are the redness.
So,
Increase in
any
temperature,
joint
tenderness.
is any. See, you are jumping. Don't jump. I'm telling what not talk is only inspection. So inspection, if you have to inspect, you have to inspect the local skin condition. Then you have to inspect the bony landmarks. Basically, two things are there. Anywhere, soft tissue and bone. Understand? So while inspecting, you have to see the soft tissue, then also the bone. Any deformity or any displacement or any angulation, any abnormality that you have to see with your naked eyes. Inspection means only inspection, nothing else. And how do you inspect them? In this case, how do you inspect? Was there any slab there?
No, sir. There is no slab.
So how do you inspect?
Sir,
So you inspect from front, back, and sides.
yes, sir.
Very important. You have to do a 360-degree inspection.
Yes, sir.
Always, any joint, any part of the body, it has to be circumferential inspection. You cannot comment on just on single one side. You have to see from front, sides, and back. Understand? So what are the palpatory findings?
There is no local rise in temperature in comparison to normal side. And
How do you check for temperature?
sir, by touching from the back, dorsal of the hand, sir.
Why?
Sir,
Why dorsum of the hand? That is a sensitive area. So that's what we do. And how do you check for temperature?
temperature. सर टच करके लोकल जो नॉर्मल साइड है उसको
पहले हाथ किधर लगाएंगे?
सर
पहले
पहले नॉर्मल साइड पे लगाएंगे फिर
नॉर्मल लगाएंगे, नॉर्मल नॉर्मल.
Yes,
That is the way you compare the temperature. So then उसके बाद और palpation और क्या findings?
there was no tenderness apart from the local scars were there operative scars. There was no tenderness noted and no abnormal mobility noted as in comparison to when the patient arrived to us.
How do you check for mobility? That is exercise.
Sir, into coronal and sagittal plane, into appendicular planes, we check for the abnormal mobility. Sir.
Do you think it is in acute cases you should check or the patient will allow for checking?
No, sir, not in acute cases.
Most of case, do you think it's advisable to
No,
check
sir.
for?
No, sir.
So the thing is that in any format of examination of musculoskeletal system, there is a fixed format. You have to go by that. But in all cases, you cannot do all tests because of certain limitations. In that case, you have to tell the examiner that sir or madam, I cannot do this because of this problem. What you getting a point or not?
Yes, sir.
So it's not advisable to check for capitals in most of case. Patient will kick you. You will good amount of solid kick. Understand? So you have to use your brain also. Always. Keep your mind open. Understand? You getting a point or not?
Yes, sir.
You have to go through a fixed format. You cannot deviate from the format. And you should do relevant examination. And if you are not able to do it, you tell the examiner that, sir, madam, I am not able to do this because of this problem. For example, if you cannot check a gait for a TB patient. TB patient who has come with paraparesis, if you make him walk, you will convert a paraparesis to paraplegia,
Yes, sir.
complete paralysis. So always you have to use your brain. Understand? So anything else? Any permission?
Patients.
That's all. You will check for the joint movements, movement of the joint.
Sir, one joint above and one joint below.
What are the findings?
Sir, both the joints were normal range of motion, sir.
Then anything else? Permission?
Sir,
Will you not like to check for distal universal status?
distal neurovascular status was normal.
Okay. Then look, feel, move. You are telling all joints were normal.
Yes, sir.
And what about the measurement?
Measurement was normal, sir.
How do you measure?
Sir, for TBR, we go from TD to velocity to the medial malleolus. On both the sides, it was normal, same.
Length and the arms.
Yes, sir.
And in this case, you have what procedure is done?
Sir, TPN healing, sir.
So in the post-op case of TBN healing, what things you are expected to see?
Sir,
One thing you tell about leg. Anything else?
sir, foot movement normal, opinion, then finger
You have to
movement.
do joint movements normal. Anything else? Now you have done a TBN healing.
Yes, sir.
Patient is lying on OT table.
Yes, sir.
What things you will see?
So, update हो रही है बात में.
So you इतने सारे TBN healing हो चुके हैं.
Yes, sir. SPD check करेंगे.
SPO2 चेक करोगे. कर लिया. डिजिटल पल्स चेक किया. ठीक है.
Yes, sir.
इसके अलावा सबसे इम्पोर्टेंट क्या है एज अ सर्जन?
सर स्वेलिंग तो नहीं आ रही है अपडेट होने के बाद.
स्वेलिंग. एनीथिंग एल्स इमीडिएट पोस्ट ऑप में क्या देखते हैं? आपने अभी रीलिंग किया और पेशेंट इज गोइंग टू शिफ्टेड टू पोस्ट ऑप एरिया. व्हाट यू विल चेक? व्हाट इज द इमीडिएट कंसर्न?
सर टॉनिक के लगा रहा हूँ.
लगाते हैं टोनिक क्यों नहीं? देखा नहीं लगाते हो?
Yes, sir.
हैव यू सीन?
Yes, sir. एक दो
इसको देखा है.
तो सर वो पहले दे दूँ उसके बाद से तो लगवाया था.
यहाँ आप लगते हैं टोनिक.
सर अभी होता है.
I believe रीलिंग शुड नॉट डन विद टोनिक. चलो ठीक है व्हाटएवर. इमीडिएट कंसर्न क्या है? विल नॉट चेक फॉर एनी रोटेशनल एब्नॉर्मलिटी. रोटेशन नहीं देखोगे. आपने पाँव पाँव को उल्टा जोड़ दिया, सीधी अंदर जोड़ दिया. वे नीलिंग प्रोसीजर आपने किया है.
We will go for this year.
सुनो बात. आप मरीज को अपने नीलिंग के बाद आप देख रहे हो पाँव. नॉर्मल रोटेशन क्या होता है पाँव का? देखा है नॉर्मल रोटेशन
10 to 15 degree external rotation
होता है ना?
Yes, sir.
दैट यू विल चेक और नॉट.
Yes, sir.
कई बार इंटरनल रोटेशन नीलिंग हो
Yes,
जाती
sir.
है.
Proximal
कई बार रोटेशन बढ़ जाता है.
Yes, sir.
So this is an immediate concern.
Yes, sir.
कहीं आपने इंटरनल रोटेशन में तो नहीं इसको ठोक दिया
Yes, sir.
या रोटेशन बहुत बढ़ा दिया आपने. तो मेन कंसर्न इज length angulation rotation LAR. This is LAR. The whole purpose of doing surgery is you have to maintain the length, angulation and rotation. Rotation is very important.
Yes, sir.
मान लिया आपने पाँव इंटरनल रोटेशन में कर दिया तो मरीज कैसे वॉक करेगा?
Yes, sir.
Imagine करो how the patient will walk. Will his gait be normal?
No, sir.
Then rotation is of prime importance. Whenever you are fixing a fracture, rotation is very important. Otherwise, you will, if you don't correct, if it is mal rotated, just imagine this flight in post op. क्या होगा सर? समझने वाला. चलिए. So what are the complications you expect in TBN?
Sir, TBM has a tendency to go.
I am telling you complications. When I told complications, it is immediate, late, intermediate. So what immediate complications you expect? What are the intermediate complications and what are the late complications you expect?
Sir, immediate complications are it can result in compartment syndrome.
Very good.
Then sir, sir late में सर नॉन यूनियन आ जाता है इसमें क्योंकि मसल कवर इतना होता नहीं है टीबिया के ऊपर. इज वेरी लेस अमाउंट ऑफ मसल कवर ओवर टीबिया, सो मसल सप्लाई ब्लड सप्लाई इज लेस. They it can result into non-union. Then complications, patient-related complications.
How do you check for compartment syndrome in post op?
Sir, we will look for the intercompartmental pressures and we will
Have you measured?
No, sir, not in.
Have you seen?
It can be. It can.
I have not seen till my
Yes, sir.
Indian setup. I don't have that.
Yes, sir. We can go for clinical.
What are the clinical findings?
Sir, pain out of proportion.
Very good.
Then paresthesia, paralysis, pulselessness. This last two comes up. Then and pain over a passive stretch. These are the signs and symptoms of.
Most important is?
Sir, most important is pain on passive stretch.
It is passive stress or inappropriate pain. That is which one is?
Oh, sorry, sir. Pain on pain out of proportion.
Out. That is the most important
Yes,
thing.
sir. Yes, sir.
You have see some amount of pain is expected in post op.
Yes, sir.
But even after giving painkillers, sufficient amount of painkillers, pain is not subsiding.
Yes, sir.
and it's increasing, then you should always keep in mind
Compartment syndrome.
compartment syndrome. Okay. So, uh, see, which sort of fractures, tibial fractures, are more prone for compartment syndrome?
So tibial shaft fracture.
Tibial shaft. Anything else? Close or open?
Sir, sir, close or open दोनों ही हो सकते हैं sir. It depends upon the compartment. If the bone is piercing the anterior compartment and there is swelling in the posterior one, then the compartment syndrome can occur in the posterior one also.
Which one is more prone? Close or
Anterior,
open?
anterior,
Close fracture, open fracture, which one is more
close,
fracture?
close is more, close fracture is more, more inclined towards compartment syndrome. Sir.
So, what are the compartments of the tibia?
So there are four compartments: anterior, lateral, posterior. Posterior is divided into superficial and deep. Sir.
So, if your patient develops compartment syndrome, how will you manage?
Sir, we will first look for the delta pressure. That is the difference between the diastolic and the diastolic and the intracompartmental pressure. That must be between for the to diagnose compartment syndrome. That should be in between 10 to 30 or less than 30. And if it is there for continuous 2 hours with multiple readings of it, then we have to go. We have to.
Do you have this machine in your work?
No, sir.
Then?
Sir, it is basically done on the. It's an emergency condition, so clinically we have to diagnose it and we have to proceed accordingly.
So, what, say, it has developed compartment syndrome. Now, what do you do?
So then we have to go for fasciotomy and
Where is the incision?
sir, there are two type of fasciotomy: single incision and two incision.
Which one is better?
Sir, the single incision is much better because we can examine the whole muscle through it.
Single incision, where you give that incision?
Yes, sir.
Where you give that incision? Where you give the single incision?
Sir, from fibular head to the jadeve's tubercle, in between, at the midpoint of it, from there we go for the starting point of the incision.
Fibular head to jadeve's tubercle. So, how do you will you decompress the which compartments will decompress by this incision?
Which compartment? Sir, this is sorry, anterior and lateral compartment will be decompressed by this.
And posterior compartment छोड़ देंगे.
Sir, अगर उसमें होगा तो सर उसमें फिर
कैसे? It's very difficult to tell. You have to ideally decompress all the four compartments.
yes, sir.
ठीक है. You cannot decompress only one compartment. Nowadays, double incision you have to use.
Yes, sir.
You have to completely decompress all the four compartments. Then only you are sure that you are relieved of the pressure. Understand?
Yes,
So what is the time limit for irreversible ischemia in the leg? How much time lapse is there after that? It is beyond retrieval. The whole thing is necrosed.
24 to 40 years.
24 days is a big time. It's not 24 days. It's quite less than that.
So,
How much time the muscle takes to necrose and how much time the nerve takes to necrose?
Sir, we have to monitor the patient. And if
What is the critical time? Critical ischemic time. What is it that time? If you don't intervene in that time,
6 hours.
yes. It's less than 6 hours, 6 to 8 hours.
Yes, sir.
If you delay by beyond 6 hours, you will lose it.
Yes, sir.
Completely you lose it. So you have done a fasciotomy. Will you close it?
No, sir. We will put patient on external fixator, sir. And we have to remove that.
Why external fixator? Already you have done a nailing there.
Sir,
After nailing, again you have to do something else. What is the name?
sir, बिल्कुल exactly kneeling को remove करना है कि नहीं करना है. But that's what I read कि we have to put it on an external fixator.
You want to do the nail?
And
You already stabilized.
yes, sir.
So why do you want to destabilize the fracture?
Sir, because of excessive rimming,
excessive reading can lead to what other very important complication.
So excessive reading can destroy the blood supply of bone.
So
So that
how
can
it is
result
related to
in
compartment syndrome?
yes. So it releases lots of heat energy, sir. By
Now,
breathing.
how it is related to compartment syndrome? Like, is it,
Not blood supply is not
ah,
related to it, sir. I was like, a non-union.
so I'm telling you, you have done a fasciotomy,
Yes, sir.
nail is there. What you will do the post protocol? Post इसका protocol क्या रहेगा आपका? आपने you have done a fasciotomy.
So for 24 to 48 hours, we will have to keep the wound open, and then we have to look for the primary closer if it is possible. If
You
it is
have
not
to
possible,
do a relook department
yes,
again.
sir. Yes, sir.
Again, you have to take the patient
Yes, sir.
and see whether the muscle mass is healthy or
Yes, sir.
unhealthy,
Yes,
or
sir.
you have to keep removing the unhealthy tissues.
Yes, sir.
You have, because there is no point keeping necrosed tissue.
Yes, sir.
If something has gone, you have to remove it completely. कोई भी डेड टिश्यू का कर नहीं सकते हो, so you have to
Yes, sir.
do multiple debridements and if possible you do try slightly closer.
Yes, sir.
Okay, not otherwise if it is not possible, then what will do, you will take help of your plastic surgery
Yes, sir. Plastic surgery. We can go for split scaling graft, sir.
or flaps
Yes, sir.
depending on
If,
the
if,
condition.
if the muscles are healthy, not healthy, then we have to go for the flap, sir. If it is healthy, then we have
Why?
split, sir.
Why flap will take in a unhealthy muscle? First thing is that you have to make it a healthy bed.
Yes, sir.
Whether you do a skin
First
graft or whatever
we
you
have
do,
to remove the unhealthy.
if there is some necrotic part, you cannot do anything.
Yes, sir. First we have to
You have to
remove
wait.
the necrose part and then.
You have to settle down completely.
Yes, sir.
Read this X-ray.
It's an X-ray of um, it's an X-ray of left left leg showing both tibia and fibula with fracture of distal end of with interlocking intermedullary nailing in situ with fractured end of distal end of the lower one third of the fibula and there's a spiral fracture of tibia in the lower distal end is noted.
How do you read an X-ray? What are the points while see you have straight away jump to diagnosis. How do you read an X-ray? What are the steps of reading an orthopedic X-ray?
X-ray of left leg, AP lateral view showing
Of a skeletally mature or immature?
skeletally matured.
Why?
Sir, epiphysis fused as a
Very good. So it is a skeleton of a mature skeleton. So how do you read? What is the formula of reading an X-ray?
so we look for the first soft tissue.
No. Have you read ABC in your nursing class?
Yes, sir.
So there is a ABCS approach. What is A? A is whether the first thing that you see in X-ray is whether the films are adequate or inadequate. So you cannot comment on a bad X-ray. First and foremost, whenever you get an X-ray, you should see that the films are not overexposed, underexposed. If you get a bad quality X-ray, how will you comment? You should repeat that X-ray. So A is for adequacy of the X-ray. What is B? B is bones. You have to look at the bone condition of the bone, whether it is any areas of sclerosis, any areas of your lysis, so hypotenuse or these areas, that is B. And C is cartilage. Cartilage means joint space. Joint space is okay. Little bit valgus is there, but S is soft tissue. So this is ABCS approach in any X-ray that you read. Understand? Straight away should not jump. So in this case, it is a post-operative case of tibial nail injury. Okay. So So, do you think this procedure has been done well, or something you see with this fixation?
Yes, sir.
Hmm?
Yes, sir.
Satisfied. Okay. Uh, See, this fr- fibula fracture is of the lower third. I mean, lower third and on lower one sixth. So, do you think this fixation was more? I mean, it would have been more beneficial. You have put the done the fixation of fibula also. How much part of the fibula is the ankle mortise? I mean, see, fibula is a spare bone, given by the God. But how much fibula is very essential for for normal mechanics of the ankle joint?
5 centimeters.
Hmm?
5 centimeters.
5 centimeters. How do you measure? What is the length of the fibula? How can you tell 5 centimeters? It is 5 centimeters fixed. It can vary in the person to person.
Yes, sir. According to my documents.
That this lower one sixth of the fibula is important. See, lower one sixth of the fibula is very important. The whole other thing is spare. That is a spare part given by God. You can use fibula in various conditions. You have seen also.
Yes, sir.
But lower one sixth, you cannot when use a you cannot. It has to be kept intact. Got it? So it had been ideal if something had been done here. Anyway, it's done good. So one more thing, can you see proximal fibula? Can you comment on the proximal fibula?
Proximal fibula is
So
also fractured.
what is the concern there? What the fracture is? Do you think it can lead to any problem that fracture of the proximal fibula?